Thank you, and welcome to the session, which is called COVID-19 Data Definitions and New Data Types in a Crisis. I'll just introduce the session briefly, and then we'll go straight on to introductions for the speakers. So a little bit of background to this. So data collected in healthcare systems isn't collected with research in mind. We know that. It's sparse, it's sporadic, it's subjective. It's often only collected during periods of sickness. So healthcare is often sick care. So it's hard to extract meaningful data and knowledge from these closed proprietary systems as well, and difficult to integrate, let alone harmonize with other health systems and other non-health data. So we need to think about how we can improve access, link and share this data rapidly while ensuring data standards and metadata. And there's also the opportunities and challenges for how we deal with new types of data for research, and how do we integrate that data with traditional health data collected either during routine care or research settings. So how do we do that? And that's especially, has been especially and is especially important as we think about COVID-19 research. And so the advent of wide bandwidth mobile networks, smartphones, wearable devices, and Internet of Things have really kind of provided an opportunity for continuous remote monitoring and passive monitoring at the population level. And that's not just during periods of sickness, but that's all the way through the health and disease continuum. And so that provides us with a real opportunity again for COVID-19. And but there's obviously, there's an obvious tension between public health and civil liberties for contact-19 tracing apps. But we don't just have to think about this kind of technology in the context of contact tracing. We think about this in the context of digital surveillance, and not necessarily equating to just contact tracing. And so remote monitoring can support our understanding of disease onset and disease trajectories. It can provide regional disease surveillance and help and support a safe lockdown release. It helps us understand behavioral changes and compliance with non-pharmacological interventions, policy interventions, for example, at a national level and local level. And so the addition of that to that of wearables also provides the opportunity to learn from large-scale, passively collected data that could help in predicting epidemics. Unusual changes in resting heart rate, for example, may indicate a viral illness. So with that, I just want to hand over straight over to Helen, who will introduce our first speaker today. Thank you.
Okay, so thank you very much, Richard. While I'm doing this, Tim, would you be able to start sharing your slides, please? So when I finish, we should be good to go. We're pretty much on time, which is encouraging. So I'm pleased to welcome Professor Tim Spector from King's College London. He's going to provide us with an update on the COVID symptom study app. This morning when I looked, it was 3.8 million contributors to the app. I think the numbers have gone up a little bit since the slides were made. Tim is Professor of Genetic Epidemiology and Director of the Twins UK Registry at King's London. And he's a specialist in twin studies, genetics, epigenetics, and microbiome and diet. So Tim, welcome, and please start your presentation, and we can see your slides.
Okay, so this is all about the COVID symptom app, this citizen science project, which we probably believe is the largest one that's ever been done on health. It's got nearly 3.5 million users across the UK. It's also in Sweden and the US. And it really looks at predicting symptomatic COVID via an algorithm without needing a test. And it predicts it using a cluster of symptoms, and it's now helping the NHS, the Department of Health, and doing real-time research on risk factors. And it was set up as a not-for-profit initiative by health science company Zoe that I was working with at the time on a nutrition app just before we entered lockdown in mid-March, and my university, King's College London. And this all happened really by serendipity. I was really keen to get our twins tested, and we decided to have an app to do that. And I asked this company whether they could help us out, and they managed to amazingly build this app in 4 days and get it launched on the 24th of March. and we didn't expect it to have the success that it did. But it basically, within 36 hours, we had 1 million downloads, and within 2 weeks, 2 million, and we're currently at nearly 3.5 million. And there's about 1.5 million regular loggers still. A lot of people dropped out who had disease and have stopped following us. But a couple of weeks after starting, we managed to get the support of the Scottish government and the Welsh government and the NHSs, all the major charities in the UK, plus all the royal colleges. We still don't have endorsement yet from the NHS England, but really got a massive support from the people and the charities. And the whole idea is to really try and predict symptomatic COVID using machine learning, where you take a sample of the individuals who are having COVID tests with PCR, self-reporting them, seeing their symptoms, comparing that and extrapolating that from that training set to the larger set. So it's typical AI in the concept, and the app has allowed us to do stuff in real time that you just couldn't do with questionnaires or anything else. And unlike other apps, it asks you to log every day. And so it's not just a one-off snapshot. It's an ongoing discussion with the participants. And we're able to add in extra questions, drop some that have already answered, etc. So it's much more interactive. About a month ago, we started getting extra help from the Department of Health, who allowed us to send invitations for testing to anybody in the app who had reported for a week being well and suddenly reports not being well. So regardless of symptoms, just anything they felt was unwell, they got an invitation for a test kit, and about between a quarter and a third of them responded, and this allows us to get our numbers up. So we're over 150,000 tests, and about 10% of them have been positive. So this is really a really large training set that we're using. We've got a study underway to actually see whether our diagnostic algorithm can predict what the swab testing will produce rather than doing it post hoc. And we also have a sample of twins who have the app who have antibody tests that we're doing as part of our local study. And we've also introduced an antibody self-report on the app so people can report that, and increasingly that's happening, particularly in the 120,000 healthcare workers we have on our books. What's fairly amazing is that we only started this project in March, and we already have three papers, one in Nature Medicine, one in Science, and there's another one in The Lancet, and this list of other papers that are in various stages of publication. Just the amazing speed at which you can get things done in this emergency, in this environment, and working with the right group of dynamic people. The app allows us to pick hotspots where we were seeing above average rates of prevalence of these predicted COVID. And this is data from the beginning of April, where in the UK we saw these hotspots in various places, and one particular one in South Wales, we were able to spot this before the hospitals reached their peak about 10 days later. And there was no obvious reason for this other than there were a lot of sports events and some major rock concerts in that area. And we also found increased rates in Liverpool and Cheltenham related to other sports events, which disappeared over further weeks. The other thing we're able to do now, because previously we've been reporting prevalence rates, which at their peak were around 2 million people affected in the beginning of April, and that fell below 100,000. But the incidence rates we've been producing based on the swab testing extrapolated to the larger population have been very useful. And you can see our graph down here shows that this was still in lockdown, and then lockdown has been eased, where the rates didn't drop as much, but subsequently across England they've started to drop again. And this is all very encouraging. We're also able to look at the regions, because we have fairly large numbers, between 1 and 200 test positives out of this approximately 1 million people sampled every week. And this allows us to look at the differentials in the different areas. So most places are going down except London, which is fairly flat. These papers, as I mentioned, really were just mainly validating the algorithm that has close to 80% predictive power to spot a COVID-19 positive test. And we're working on the algorithm to continue improving it, and also to try and get the algorithm to work out what the best way of looking at early disease is, rather than at the end of a week. Because if you can pick it in the first 2 days, that's perfect for track and trace. Whereas if you leave it at the end of a week, they're probably spread it around lots of people. It's obviously more difficult. Now, this is the key figure from our Nature Medicine paper, based on 2.8 million people in the UK and the US. The dark band is the UK, the grey one is the US replication sample. And you can see out here the loss of smell is by far the most predictive of a positive PCR test. And this is followed by anorexia, skipping meals, fatigue, and then fever. And this is the ROC curve that we got there, which was pretty good. So we were pretty happy with this. The fact that it validated also in a different country is also useful. It's also validating in Sweden. This tells us the importance of collecting more than the fever, the persistent cough, which is what the UK government had persisted with, although many other countries have used a wider range of symptoms. And
Tim, your 10-second warning.
Okay, and our new data is showing skin rashes, which a relatively new sign is coming out as somewhere between fatigue and fever as highly predictive. So I won't go into this, but our sense of smell, we're able to look at really large numbers of people to show that 16% in the population have loss of smell but don't have persistent cough or fever, again showing why you need to use multiple symptoms to capture these cases. And this is a paper that's been submitted showing that we can divide all the cases into 5 clusters using our algorithm that look at different levels of severity. And these ones here have a 3 times more greater risk of going to hospital than the others. So early use of the algorithm to predict the risk cases is going to be really important. Finally, looking at symptom duration, because our app is, again, continuing to look at people, we were first to really show how many people are in this long tail, and 1 in 20 people have symptoms for over 30 days. And increasingly, this is becoming a major awareness of the health problem, considering we have, like, in the UK, something like 4 million people affected. That's going to be a lot of long-term problems to sort out. That really is where we are. So just want to thank everyone, particularly the company Zoe, King's College London, all my colleagues there. There's about 120 people working on this project. And of course, HDR UK, who have curated all the data and allow it to be sent out from anybody. And the data is available from HDR UK for the use, and it's distributed to all the NHS and other research groups. Thank you very much.
Thank you very much for the presentation, Tim. We've got a lot of questions in the chat. Please do feel free to address those in the chat and to continue to address questions in the chat while we move to our next speaker. So, and we'll hold the questions to the end as well where they haven't been answered, and there'll be a chance to ask additional questions. So I'm pleased to welcome Paul Clark, OBE. He is the Chief Technology Officer at Accardo, who are a world leader in smart fulfillment and logistics. He's interested in using Accardo's technologies and competencies to disrupt other sectors, and I think this is probably one of the most disruptive times we've seen in our recent history. And so we're very much looking forward to your talk, Paul. Please proceed, and we can see your slides.
Good morning. Thank you very much for inviting me. Next slide, please. So there's a lot of talk about open data, and indeed during this pandemic, I think we've seen data sets published for the greater good to power things like research, analytics, and modeling that might never have seen the light of day otherwise. But although that's absolutely fantastic and a really positive expression of global cooperation and collaboration, the fact remains that maybe when we're not in the midst of such a crisis, open data is going to be the gross subset of the really interesting data, most of which won't be open. Next slide, please. So let's take an example of some of our data in Accardo. As far as I know, I think we were the first major retailer in the UK to make antibody testing available for our frontline staff. And we discussed at the start of that project with HDR UK and Wellcome Trust what additional metadata we might need to collect in order to make that data set potentially useful for research purposes. In the end, the data proved not to be valuable to HDR UK for technical reasons, but our desire to help was there. Next slide, please. On a day-to-day basis, we collect a huge amount of data from our delivery vans as they fly around the country, including things like GPS and wheel speed, temperature, how fast they're cornering, how fast they're going over speed bumps, fuel consumption, and so on. And we feed those data into our routing systems to help plan future routes, but also into our detailed routing simulations to test new algorithms. Now, both those data sets are potentially valuable. As I already mentioned, we would have been happy to provide our antibody testing data to trusted organizations such as HDR UK or Wellcome Trust to help in the fight against COVID-19, but we would not have released those as open data sets. Similarly, we might be happy to provide our van telemetry data to local authorities, for example, to manage road congestion, plan roadworks, or improve air pollution, but we're not going to make those data sets available so that people can reverse engineer where our customers live. Next slide, please. So this is why we so badly need, next slide, previous slide. Why we so badly need not only data trust, but data passports to control who data can be shared with and for what purposes. And as part of this, we need to grapple with the thorny issue of how we will share data that won't be free. This includes mechanisms such as freemium models for data, data that contain jitter that you have to pay to remove, pay-per-use data, and so on. Had that sort of data sharing infrastructure been more evolved when the pandemic struck, there would have been more data available, and as a result, we could have done more with AI and modeling. Unfortunately, that missing infrastructure for digital asset management is not an isolated example. And we need to reframe our view of infrastructure to not just be things like roads, railways, and fiber to rural communities, but also the digital infrastructure needed to support all sorts of initiatives. Infrastructure is a horizontal to support many initiatives and verticals, and must not be relegated to just being part of one vertical. So we need much greater vision here. Next slide, please. Now, synthetic environments, by which I mean simulations, emulations, visualizations, and digital twins, are core to almost everything we do at Accardo, and this is one of our deepest core competencies. These synthetic environments enable us to explore physical worlds faster, cheaper, and with less risk. They enable us to use machine learning models to generate data sets before the physical twin exists. They enable us to explore and optimize these digital worlds to find solutions that are frankly beyond human scale. And indeed, when lockdown hit, our researchers and innovators headed home with their 3D printers and used these synthetic environments to largely carry on business, or rather disruption, as usual. Next slide, please. Our application of data, machine learning, and simulations is the way, or one way, is that we look after our swarms of robots. Each automated warehouse that we build typically contains more than 3,000 robots, each of which generates about 5,000 data points 1,000 times a second. That's about a gigabyte of data per robot per day, or about 4 terabytes per swarm per day. And that's in just one warehouse. Over the next 4 years, we're going to be building 40 of these around the world for ourselves and our platform customers. Now, there's no way that human engineers could monitor that number of robots and that volume of data, let alone optimize it in near real time. So what we do is we stream those data to the cloud, and there we have a machine learning based healthcare system that uses predictive maintenance to try and keep every member of the swarm in tip-top shape by spotting the onset of problems before they become problems, very much as has just been talked about in the last presentation. And this is directly analogous, I believe, to what we could do with remote medicine for humans using patient records, data from wearables, and sensors in the home. And our warehouse digital twin also uses these data to explore and optimize the operating parameters for those robot swarms, which are then loaded up into the real-time control systems. We use simulation to model and optimize other parts of our business, such as the thousands of routes our vans drive each day, and to test the demand forecasting to predict what our customers are going to buy. And then really, we're on a journey to build an end-to-end simulation of our business and our platforms. Next slide, please. So now I want to frame this within the context of the current crisis. Now, I believe that if you can stack 3 crates of different animals in the wrong order and bring down a planet, at least in terms of the dominant species, then we've clearly got a lot of missing resilience, and it's at a planetary scale, not even a country scale. And I think the current crisis has been a worked example of why you need to build tools in peacetime for the future battles you're going to fight. Now, we arguably failed to do this in the previous peacetimes. We must not make that mistake going forwards. And as part of a holistic and compelling vision for what a smart, prosperous, equitable, scalable, sustainable UK might look like, resilience needs to be a key element. We need to build resilience by design. However, I fear there is a massive risk that when we get through the immediate crisis and the sun starts shining again, that planetary oxytocin will kick in, deadening the pain that we've lived through and the price we've paid. And that could lead to a resurgence of short-term thinking, which would be a complete disaster and a massive lost opportunity. Next slide, please. Now, as this audience is well aware, catalysts can make chemical reactions occur that wouldn't normally occur or can speed up other ones. And I believe there are a set of national catalysts that can help the UK work smarter, faster, more efficiently, more sustainably, and indeed with greater competitive advantage. And I have a list of these national catalysts that I've been annoying people about over the last few years, but they're now firmly on my list of tools that I believe we need to build as part of implementing greater resilience, whether that be to COVID-20, a natural disaster, climate change, or other mega shocks. But this morning I only have time to talk about perhaps one of those national catalysts. Next slide, please. Now, our passion for digital twins extends beyond Accardo. And I, along with others such as the Centre for Digital Britain and the National Infrastructure Commission, share a vision for building a national digital twin. Now, much of the current focus is on the built environment for this, but things like, digital twins of airports or railways or the energy system or whatever. But I'm interested in the possibility of building digital twins of institutions, things like the NHS, national and local government, our financial system, and aspects of the natural environment. Such a digital twin could help us make better use of scarce resources such as energy, land, transportation network bandwidth, and so on. It could be important in helping us achieve our net zero goals. It could help us optimize the UK at a national scale, and indeed it would have been invaluable in the current crisis. The only way you're going to create that kind of digital twin is to effectively create the common frameworks, standards, and interfaces and middleware to enable the component digital twins to be crowdsourced and then connected together either directly or via data marts. This would include the shared data ontologies and data dictionaries that we need. These digital commons would act as the smart glue between those component digital twins. And a good analogy for these digital commons is the World Wide Web, a collection of standards, interfaces, and technologies that are used by everybody but owned by nobody, acting as the smart glue and the backbone that connects together a huge, diverse ecosystem of different providers, consumers, and applications. The same digital asset management I mentioned earlier needed to share data would also be needed to manage the sharing of digital twins for specific users and for specific purposes. Now, there is a fractal type pattern at play here. The fact is, wherever you look, there are big systems of systems, and they all need to build their synthetic environments and their digital twins. And some of them are thinking about that. But the fact is that each of those systems of systems, for instance, the future of the aviation sector, you know, that although that's a big system of systems, it's only part of the overall transportation sector, and that's only part of, say, you know, a national digital twin. So the fact is, we all need to be using the same recipe for this smart glue, so that when eventually, although we're working on our individual pieces of the puzzle, that we can over time start gluing together those individual parts to make something truly bold and powerful. Now, I'll finish just by saying that the concept of building a national digital twin is a truly ambitious vision, and some people might see it as unachievable, but then I would argue that projects such as Google Street View might have been seen as unachievable before it was done. And I'd love to tell you more about another national catalyst relating to crowdsourcing of data and semantic maps at a national scale, but unfortunately that will have to be for another day. Thank you very much indeed.
Thank you very much, Paul, sharing that vision with us and also providing the detail around Accardo. We will move to the next speaker, and it's my pleasure to introduce our next speaker. So Indra, welcome. Indra is a physician who is Director of AI for NHSX and a founding ambassador of One Health Tech. She supports NHSX with digital health initiatives in the National Health Service in England.
So hi everybody, thanks for joining us, and thanks Tim and Paul for the great talks. I'm quite conscious that we're moving on time. I'm not sure how long we've got until. Can I just confirm?
So we've got 10 minutes, Indra.
We've got 10 minutes. Perfect.
Yeah.
Well, look, why don't I speak to 7?
9 minutes.
And then that leaves, because I can see there are plenty of questions in the chat, and it's always quite exciting. So I'm just going to give a really brief overview of some of the work we've been doing nationally and with partners like HDR UK and others, from a data perspective on how we are looking at both the COVID response, but also setting up the NHS AI lab that we've mentioned. So I just wanted to briefly describe sort of 3 key areas, and then there are plenty more of which we could discuss, but I'm very conscious, as I said, of time. So one key area we did, people talk a lot about data and access to data, and those of you who are researchers on the call or even just trying to get your hands on data will know that it can, and I say this in all honesty, it can sometimes be quite a long and painful process, and it can take many months to even get access to what can sometimes be just a very simple file. So during this process, right at the very beginning, we partnered up with HDR UK, a lot of the NHS bodies such as NHS Digital, HRA, the Health Research Authority, to create what we called a front door process. So people could email in and say, I need access to this particular set of data for a particular reason. Now, it could either be an operational reason or it could be a research reason. And we partnered, I don't know if Caroline is on the team, but you know, many conversations with Caroline back, it feels like in the early days, but I'm sure it was only a few months ago. And I'm sure colleagues on the phone will feel the same. To say, well, how do we actually help speed up this process and work with HRA to do a very swift turnaround for ethical approvals in here? So I don't know if there were colleagues from HRA who've kind of talked about this process as well, which has meant that actually we've been able to collect quite a number of data sets across, oh, yep, Caroline is here. Perfect, brilliant. To say, here are the data sets, and here's how you actually access those data sets. So that was what we called the front door, and it's been very good. We've kind of offered people a 48-hour turnaround to say, okay, if you've asked for data, here it is. And Tim mentioned his Symptom Checker app, the Zoe app. And we have a number of other apps as well that people quite often wanted access to their data. So we set up something called, it's called the Oasis Hub, but it sits behind the data store in that it collects data, all anonymized from multiple symptom checkers to collate it so that we can use it, so researchers can use it in whichever way they need. And I've got a caveat that all of this does sit under a regulation called the COPI, and therefore if there is only a legal basis for the work you're doing, can you have access to that data? And one of the things we are looking at is actually from a research perspective, we're very conscious that moving over time, as people may have mentioned, this is a new disease. We don't really know how its impact is going to affect over a longer period of time. And there is some work we need to do about looking at how do we actually manage this data for a longer period of time that may go beyond some of the current regulations that we have. And then the third thing we've done, which is quite exciting, which is directly related with the AI lab, is we set up something called a national image database. Now, this was directly in relation to COVID. So we have, it's predominantly chest images, to collect chest images to see whether we can start developing, or people who have developed, start validating machine learning models on images that are related to COVID. And to say, again, I always find it quite, it's a really exciting space, but you've got to be quite pragmatic about this. Lots of companies come and they say, oh, we've developed this model, or we've got this piece of equipment that we want you to procure or install into the NHS. And actually the way the NHS works is it's multiple institutions or multiple different sites and trusts. And one of the challenges we have is to say, okay, you may have built a whole platform, great, or you may have built a model that works, great. So how do we actually validate that model and then insert it into a platform that may already be working? So part of what we're trying to do with the chest image database is actually A, collect the images, B, make sure that we have a diverse range of images. And I say a diverse range because I'm very conscious we have a diverse population here in the UK, and we need to make sure that our models work on everyone, not just the select few. And then once we validated those, how do we actually work with trusts, with units, to actually then deploy them back into whatever system they may have? So that kind of cycle of change that we're trying to develop is one of the things we're doing with the chest image database. Now, I don't have any slides, but all of the information I'm talking about is on the NHSX website. It's nhsx.nhs.uk. And if you look under COVID-19, you'll see quite a lot of details on our IG, the data access environment, as well as the work I've talked around the chest image database and the Oasis Hub data store. So I'll pause there. I'm quite happy to talk more, but always conscious that people will want to ask questions. So I'll hand over back to, is it you, Sushil, or Helen?
Thank you very much. So Sushil tells me that we are going to run till 11:45. So we've got 15 minutes for discussion. So thanks for that. I think we'll move to some of the questions in the chat. I can see that there's a lot of different questions, and that I know some have been answered already. I thought I might take the one from Matthew first, which was, I think, to Tim initially, but could also be answered perhaps by Indra as well, which was about the % of the population using the app, how that's representative of the wider population, and what about age and diversity measures? So which part of the population are we sampling through these application scenarios?
It's a good question. So it's clearly not totally representative of the population, but no survey ever is. So that also goes for the ONS surveys. Basically, we're getting about 4 to 5% of the population. These are obviously representative of people who use smartphones and have a slightly higher socioeconomic status. It's mainly females who tend to reply more to surveys, and we have we're underrepresented for BMA. But we still have, because of the size of our survey, with going up with these millions, we do obviously have sufficient numbers in these groups. Our main users are aged 18 to 70, but we've got now about 250,000 children, about 300,000 people in their 80s. So it's always going to be slightly biased towards the better educated, slightly healthier group of individuals, but we think it's as good as any other survey that's generally done. That doesn't, because we can't force people to take part, there's the voluntary element to it. We're clearly where we don't have any coverage at all is on care homes. And so when we're seeing rates of change in our data, that it's not reflecting what's going on in care homes, which have been a major source of infection, and so maybe why the mortality rates have stayed high while our population rates have been dropping.
Indra, would you like to respond to that question from your NHS perspective?
Yeah, and I just want to say that whilst the Zoe app is an amazing product, there are other apps as well that people should be conscious of are also collecting data. And we as well with NHS 111, so it's in partnership with NHS Digital, built in the very early stages. It wasn't really a symptom checker, but more a status checker, where people could go online. So even if they didn't have the ability to download a product, they could go online and fill out their information. But if I'm totally honest, without looking at the details, which I unfortunately don't have right to my hand, I wouldn't be able to tell you the proportion or the percentage of that population that is. But I think Jim's made a really valid point that, and this goes beyond just COVID, we have to be very mindful in this digital age that actually there will be a proportion of the population who are excluded, either because they don't have access to the products, the tools, or they're not aware that they exist, and therefore they're being excluded from that. And it's something that we're looking into for sure.
Thank you. Paul, did you want to respond to that?
Only really just to make the point that I think it's an amazing initiative, especially the speed at which it was stood up. But for me, that kind of ability to crowdsource data at a national citizen level, at a citizen level nationally, is another example of those bigger pieces of national infrastructure that we're missing. Because this should just be part and parcel of everyday life. Of course, there are huge kind of privacy issues, but it isn't just about, collecting symptoms, in a pandemic. It could be for all sorts of other purposes, whether it be, flooding, disasters, it's a missing piece of distributed democracy, I think, is my view. And that's kind of, why it's on my list of other national catalysts, which relates to this whole kind of semantic maps thing that we're looking at. But so I think it's something we should look much wider, as the previous speaker said, than just the current pandemic.
Yeah, I mean, just to echo that, we've got 1.5 million people who are, for the last nearly 3 months, have been logging on, every other day or more. And even if they're well and telling us about their risk factors, and when we add in another question about vitamin use or HRT or whatever it is, they're interacting with us. So clearly they're trusting us with their data. They are happy. We have to learn that we have to interact with them. So what they don't like about some of the NHS systems, they're just one way. They don't get any feedback, and it seems so. I think this is going forward a really interesting lesson about how to get large amounts of people doing these sort of surveys online, which cost a fraction of what it would cost to do these other surveys. And I think these really could be game changing. That once we get out of this COVID, the idea that you've got these millions of people who are happy to have an app and share it with their friends and family and log for older people or their kids, I think needs to be seized upon. And so it would be great to work with government more to see how we can extend this rather than just letting it fizzle out when the funding runs out.
Just in addition to this, Tim, and building on that, just how do you think, there are all these symptom trackers and there's the Oasis Hub. Is there a kind of much thought and effort going into having a kind of common data schema, a common data model across these apps, and thinking about that so that, we can aggregate data together?
As far as I'm aware, all the other ones are at least, only about a 20th of the size of our one. So it doesn't make sense for us to change. And all our data is open source, so everyone can see the app, and they can, we encourage everyone to ask the same questions as we do, so that these smaller apps could validate the studies and use our data. That makes the most sense. So that's the way I've understood it, and there have been a number of initiatives, and I think a lot of people did try to get apps out there at the end of March, and most of them didn't make it, and it's a bit of luck that ours managed to, but that's where we are. So in other countries, we're trying to encourage people to use our list of symptoms, and we've been trying to get the government to increase their list of symptoms for example, in the ONS surveys, so that we can actually match across our incidence data with these more systematic survey approaches. So we are trying to do that across the board, and there are some international movements as well, geared up to try and what are the common questions.
I would just say there's I've seen that Sushil has just put a link into the chat, but one thing we've just got to be quite conscious of is quite a number of products have actually pivoted. So there will be there are a number of, I think Symptom Checker apps have been out there for many years. People will know that we've been using it for both triage, but also to kind of take out the people that they want to refer on to different primary care sources. So quite a number of products out there have been pivoting what they normally do for either primary care audience or maybe a skin, a dermatological audience to COVID. And it's very difficult then, if you've already got a product that you've been building for many years, to start working, as Tim has said, it's quite difficult then to pivot around to some common standards. But I think moving forwards, it's one of the things we're really keen to push is both open data standards, but also for people to try and link together, and that's one of the things we've explored with the Oasis Hub.
I think Paul wants to. Paul, would you like to respond?
Just to make the point that, as I mentioned, sort of shared data ontologies and dictionaries in my talk, this need for that kind of shared infrastructure around data is way bigger than even the idea of combining these apps together, and it's absolutely central to some of the work that we're doing on the AI Council, and indeed its analog in the physical world, which is the Robotics Growth Partnership, because you're not going to glue together synthetic environments unless you have a common understanding for the data ontologies, and it's probably one of the most important pieces of work that we could do as a country, in terms of supporting infrastructure, is to get that kind of those kind of shared ontologies in place. And so but there is a significant coalition of the willing that is kind of grappling with this, but we need to actually make it happen.
Thanks very much. And as somebody who builds ontologies for a living, that's really comforting to hear. I think we've got time for one last question, and it's the most recent one in the chat, which was Sheng Chue, who asked, for an app to be effective in contact tracing, it's going to need to reach more of the population than we're reaching now. He says 60 to 70%. So how are we going to get to that point where we can get better coverage of the population, and also equitable coverage?
Yeah, at the moment, our estimates last week were there were 4,000 new cases, new incident cases per day in the UK, and that was similar to the ONS survey data. And I think the track and trace estimated they were picking up about 1,000 cases and tracing those ones. So currently missing about 3/4 of the cases, and that's a combination of reasons for that. I guess is needs more testing, but I think a broader approach to how you capture those cases. And I would suggest, and we've suggested that if our app, for example, was supported by government and had some PR behind it, then you would just get 3 times as many people using it. You would at least double the number of cases you were able to pick up and contact trace. So that's something we put on the table, and it hasn't come back as any great support, I think, because of some of the politics around the track and trace app, which is very different based on Bluetooth. But I think it needs a number of approaches. So it's not just endorsing things like our app or other apps, but it's also more systematic testing, particularly in hospitals, retesting people every week, these kind of things as well as part of that big package to get the missing 75%.
Thanks, Tim. So Indra, would you like to respond to that? I think we've got a couple of minutes left just to hear your response.
Yeah, I would just say they've got a really valid point. A voluntary app can be quite difficult to ensure a large coverage. We found that with the NHS app, so regardless of COVID, we built an NHS app, which was primarily there to help sort of repeat prescriptions, booking appointments, etc. And what we found was actually quite, majority of people didn't necessarily download the app, but they used the web browser to use the functionality. Linking data behind the scenes, again, is something we are working at. We already work very closely with NHS Digital and ONS, as I said, through that front door process, as well as HDR UK and a bunch of others. So that is already happening behind the scenes. And in answer to your question, there are politics around apps, which is fine. But what I would say is we need to understand there are a broad range of products out there as well. And we need to understand how we actually reach those communities who may not have digital products and collect their data as well. And one of the ways we went around that was to donate devices to those as well. So I'm conscious of time, so I'll stop there.
Thanks, Indra. So wonderful presentations and great questions. So Sheil tells me that we are going to collect the presentations and they will be shared as far as they can be. And also we're going to collect all of the questions out of the chat, and we will ask our colleagues on the panel to answer those, and we'll be able to publish them on the website. So if you didn't get your question answered, thank you for answering it. I can see some were answered. We appreciate the intensity of the questions. This has been a really rewarding experience to attend, and thank you very much to everyone. And I think we'll be moving to the next part of the meeting now.